When you picture an emergency surgery, what comes to mind? It's probably the surgeon, right? Scalpel in hand, ready to go. But what if I told you the race to save a life actually starts way before that first cut is ever made? It starts in the unseen, high-stakes world of emergency anesthesia.
Yeah, it's true. Because in those absolutely critical moments, there's another expert in the room, making these split-second decisions that are all about stabilizing, protecting, and basically managing the patient's very life force. So today, we're going to pull back that curtain and really look at the anesthesiologist's role when every single second counts.
All right, so let's get right into it. The very first step, sizing up the emergency. The anesthesia team has to figure out what they're walking into, like immediately. Because here's the thing, not all urgent surgeries are the same, not by a long shot.
And this is where it gets really interesting. Look at the precision here. A true emergency, something like a ruptured aortic aneurysm, the team has less than an hour to act. That's an entirely different universe of pressure compared to an urgent case, say a bowel obstruction, where you might have up to 24 hours. This one classification right here, it sets the entire pace, the entire strategy for everyone involved.
So this is the point where the anesthesiologist basically has to become a detective. Seriously, the patient is often a total mystery. They roll in with a diagnosis that's maybe uncertain, a bunch of medical problems that are completely out of control, and their body is just in physiological chaos. And the team, they have to solve this incredibly complex puzzle while managing the crisis at the exact same time.
So how do you bring order to that kind of chaos? Well, you rely on a rapid-fire assessment. This is not some leisurely chat, It's a super-focused checklist, and it's all about grabbing the most critical info as fast as humanly possible. And that checklist, it zeroes in on three absolutely vital areas. First, their cardiorespiratory status. What's their heart and lung history? Second, functional capacity. This is basically a quick and dirty way to gauge fitness. You ask something like, hey, can you climb a flight of stairs without getting winded? It sounds simple, but it tells you a ton about their body's reserves. But, and this is the big one, the absolute top priority is the airway. Because if the patient can't breathe, literally nothing else matters.
Now, in a trauma situation, you don't have time for fancy lab tests to figure out how much blood has been lost. So instead, the team becomes expert at reading the clinical signs. A heart rate that's creeping up while blood pressure is dropping, that's telling a story. For instance, something called orthostatic hypotension, where your blood pressure just tanks when you sit up. That's a huge early warning sign. And if that heart rate starts screaming past 140 and the systolic pressure plummets, they know they're looking at severe, life-threatening shock.
And when it comes to that blood loss, there is often a magic number that they're looking for, 7 grams per deciliter. This number, it's a measure of hemoglobin, and it's often the critical trigger point. It's the line in the sand that says, okay, it's time to give a life-saving blood transfusion, right now.
Okay, so they've got the critical data. Maybe a blood transfusion is already in progress. Now it's go time. But this isn't just making it up as they go, no way. It's a meticulously structured 5-phase plan. You can think of it as the anesthesiologist's roadmap, the guide that takes a patient safely from total chaos all the way to recovery.
And this roadmap, it's broken down into 5 distinct phases, and each one has its own supercritical goals. You've got preparation, then induction, maintenance, reversal, and finally postoperative management. Let's walk through what each of those really means.
All right, phase 1, preparation. This is just a flurry of controlled activity. The team is grabbing every single piece of airway equipment you can imagine. They're putting in these large IV lines. We're talking wide bore for fluids and blood. And this is so important because these patients often have a full stomach. They're taking steps to decompress it and give meds to prevent aspiration, which is when stomach contents go into the lungs. That can be a fatal complication, so they're all over it.
Next up is phase 2, induction. This is the going to sleep part, but it is absolutely not one size fits all. So let's say you have a patient with a full stomach who's at a high risk for aspiration. They're going to get what's called a rapid sequence induction to protect their airway in a matter of seconds. But take that same technique and use it on a frail, elderly patient, it could be dangerously harsh. So for them, it's a much gentler inhalational induction using anesthetic gases to keep their blood pressure from crashing.
So once the patient is safely asleep, we hit phase 3, maintenance. And I gotta tell you, that word is a little misleading. It sounds passive, right? But it is anything but. This is an intense, active process. It's a constant balancing act of managing unconsciousness, controlling pain, and supporting every single one of the body's organ systems, minute by minute, for the entire surgery.
And how do they manage all that? Well, think of the anesthesiologist as a pilot in a cockpit, and they're staring at this incredible dashboard of monitors. They are constantly tracking blood pressure, the ECG for the heart, oxygen levels, but also something called capnography. That measures the CO2 in every single breath, and it's a crucial indicator of both breathing and circulation. This constant stream of data is what keeps the patient stable during the surgical flight.
Phase 4 is all about waking up, and let me tell you, this is just as controlled and critical as going to sleep. The whole process kicks off with the surgeon's very last stitch. The anesthetic drugs are stopped, the airway is carefully cleared out, and then reversal agents are given to counteract the muscle relaxants. And only when the patient's own protective reflexes are back online, only then is it safe to remove that breathing tube.
But wait, we're not done yet. The anesthesiologist's job doesn't just stop when the patient is wheeled out of the operating room. Nope. The fifth and final phase actually extends into recovery, making sure that transition is as smooth and safe as possible. Now, for the absolute sickest patients, the next stop is the ICU, the intensive care unit. And that decision to transfer them isn't a guess. It's based on really clear criteria. Does the patient still need advanced breathing support? Are 2 or more of their organ systems failing? Basically, in these super complex cases, the high-level critical care that the anesthesiologist was providing just continues, but in a different setting.
And I think ultimately, this is the real takeaway here. We kind of need to reframe how we think about this specialty. Because in an emergency, the anesthesiologist is not just the sleep doctor. They are a full-on critical care physician. They're managing physiology, pharmacology, resuscitation. They don't just manage sleep, they manage life itself.
You know, it really makes you think, doesn't it, about all the other unseen experts working behind the scenes in these moments of crisis. And it leaves me with a question for you. What other critical roles in medicine do you think deserve a much closer look?